Good morning, everybody. Welcome to Clinical Approaches in Cardiology. We feel very happy today because we have here Dr. Candice Silversides. She is the chair of the cardio-obstetric clinic at the Miles Nadal Heart Center in Mount Sinai Hospital at Toronto. She's also a professor of medicine at the University of Toronto, and she also works at the Peter Monk Cardiac Center in acute congenital heart disease, adult congenital heart disease, and echocardiography. And she is also the editor-in-chief of JACC Advances. So welcome, Dr. Silversides. It's a great honor for us having you here today. And without further ado, you can start.
Excellent. Well, thank you very much for inviting me to join your rounds today. I'm really honored. Greetings from Canada. And as you heard, I'm from Toronto, and also the editor-in-chief of JACC Advances. And just so you know, this is a new JACC journal from the American College of Cardiology, and one of our focuses is cardio-obstetrics. So please read it, get the table of contents, and you'll see what's new in cardio-obstetrics. But what I was going to do today is do a very broad overview of cardio-obstetrics for you. So I have three objectives. The first is I want to tell you a little bit about the history of the field. Then I want to look at lifetime cardiovascular risk for women and how pregnancy impacts lifetime cardiovascular risk, with a bit of a specific focus on women who have pre-existing heart disease that we see as cardiologists. And then finally, I want to wrap it up with talking about some of the standards of care that have been established in the last, 5 to 10 years that we follow, so that everybody's aware of where to track down standards of care if you need to look up things. So to start with the history really started with rheumatic heart disease in the early 1900s, because that was the predominant lesion that was seen in young women of childbearing age. So if you look at one of the first books on pregnancy and heart disease, this was by Sir James Mackenzie, a Scottish physician, and you look at the table of contents, really all of it relates to rheumatic heart disease and variations on rheumatic heart disease or atrial fibrillation associated with rheumatic mitral stenosis. So that was really all the early literature and all of the clinical experience in young women. Here's an example of an excerpt from the book. He describes a case. In fact, most of the book is cases. And he says the heart affection most frequently causing danger for young women is rheumatic mitral stenosis. He gives a case of a 35-year-old woman. She came in at 7 months gestation. She was edematous at the time. She worsened over the course of her pregnancy. As labor progressed, she became progressively more short of breath, more edematous. They tried to prop her up in bed, but couldn't deliver her, and ultimately she didn't survive the pregnancy. So as you can see, in those early days, really, especially for women with severe heart disease, pregnancy was pretty bleak because of the hemodynamic stresses. And then what evolved in the field is this emerging number of young women who had congenital heart disease. And I think for those of you that know a little bit about congenital heart disease, what you'll know is that over the last century, we've really had a significant increase in adults with congenital heart disease for many reasons, but a large part has been due to increased surgical survival and also post-op care of patients and anesthetic care. And if you look, this is just the history of tetralogy of Fallot as an example. If you started back in the 1930s, you see most patients by the time they were childbearing age would not have been alive. They just wouldn't survive. And surgery started to be developed, initially palliative surgeries and intracardiac repairs. And in the current era, the life expectancy with tetralogy of Fallot is almost that of the general population. So you can see there's been a significant improvement in the survival of complex congenital heart disease. And so we've seen an emergence of that. And in fact, nowadays, there's more adults in North America than there are children with congenital heart disease. It's in fact a disease of adulthood. And then we're seeing a really increasing trend over the last, say, 10 to 15, maybe even 20 years, is that we're starting to see more acquired disease in young women of childbearing age. And that's for a number of reasons, but one of them is the fact that we're seeing more advanced maternal age. So this is just a 10-year interval. If you look on the x-axis, it's a decade long. It's data from the CDC in the United States. But if you look at the age at first pregnancy on the y-axis, what you'll see is that it's been increasing, even only in that short period of time. The difference between urban and rural centers is significant as well, but the trend is the same, which is women are having children older ages, and with that comes more comorbidities, including cardiovascular disease, including cardiovascular disease, for instance, such as hypertension. So again, on the x-axis here, what you'll see is that 10-year interval. And what you can see is it increased during that time. The number of women who have hypertension prior to pregnancy. So just highlighting that issue that comorbidities are increasing along with advanced maternal age. And then I don't want to comment on Colombia because I don't know if you have the exact same trend, but certainly in Canada and the United States, we're also seeing more women with who have obesity, more women who have obesity or who are overweight. So this is a graph again from the United States CDC data, just showing the rates of overweight and obesity in women of childbearing age, stratified according to race and ethnicity on the x-axis. And what you see is the dark blue and the lighter blue bars represent overweight and obesity. And in almost every race category, what you see is more than 50% of the women of childbearing pre-pregnancy weights are in those two categories. And again, with obesity comes more maternal heart disease, including atrial fibrillation, obesity, cardiomyopathy, hypertension, and so on. And so that's kind of been the evolution of pregnancy and heart disease. In 2019, we recoined the field and called it cardio-obstetrics. And so that's what the field is now called. But it's basically been a field that's been evolving over the last century, really. So I wanted to put pregnancy in perspective of a lifetime risk for a woman. So let's talk about the lifetime risk of cardiovascular disease for women. It's impacted in a major way if they have pre-existing heart disease. And that's really a lot of the patients I see. I see mostly women who have some form of pre-existing heart disease, whether it's congenital, acquired, valvular, arrhythmic, but that obviously impacts their lifetime risk. And then what happens over their lifetime if they get acquired atherosclerotic cardiovascular risk factors like hypertension or obesity, not related to pregnancy that I've shown you, but just independent of that, that impacts their lifetime trajectory. And then there's pregnancy. And the issue with pregnancy, well, first of all, at least in North America, 80 to 85% of women will have a pregnancy. So it can impact their lifetime risk. And that's because pregnancy is a hemodynamic stress. There's an increase in preload, which you could imagine might be poorly tolerated. For instance, if you had a cardiomyopathy, if you had pulmonary hypertension, if you had significant valve disease, there's an increase in heart rate. So that could be detrimental if you had mitral stenosis, where you lose your diastolic filling time, or for instance, if you have an arrhythmia that's somehow impacted by heart rate. There's also those two variables increase your stroke volume, so and then your cardiac output. So your cardiac output increases significantly. And again, if you have significant heart disease, you may not tolerate a prolonged increase in cardiac output. Or if you have, for instance, aortic stenosis and a fixed outflow tract lesion or obstruction from any cause, you may not tolerate increased cardiac output. It's also a prothrombotic state. So for women with arrhythmias, that can be dangerous. For women with mechanical valves, it can be particularly dangerous, and they represent a high-risk group. And for women who've had thromboembolic complications or arrhythmias, that can be an issue. The increased stroke volume in preload stretches out your heart. So from a mechanical perspective, you're also more likely to get arrhythmias if the atria stretches, but also the hormones of pregnancy are impact the action potential. So pregnancy is felt to be a pro-arrhythmic state. And finally, for some lesions, there is an increased bleeding. So women with cyanotic heart disease or Fontan circulation, complex congenital heart lesions, they may be prone to bleeding, and obviously for many reasons you can bleed in pregnancy. So you can imagine this is the perfect storm if you already have pre-existing heart disease for complications to occur. And in fact, that is what happens. We see various types of complications during pregnancy for women who have heart disease, and we kind of cluster them into the cardiac complications, such as heart failure or arrhythmias, obstetric complications, and in that we've historically put gestational hypertension and preeclampsia and gestational diabetes, and then fetal and neonatal complications. And those are complications for the fetus and neonate and include low birth weight babies, IUGR, prematurity, placental abruption, and stillbirths. And I actually didn't list it here, but I probably should have also for those women that have an inherited form of heart disease, like congenital heart disease, inherited arrhythmias, inherited cardiomyopathies, Marfan syndrome, etc. Those women also have increased risk of transmission of heart disease to their offspring. So that's kind of generally how we think of the risks. And I'm going to talk a little bit about each of them. I'm going to start with the cardiac risks. For women with heart conditions, the main complications are related to arrhythmias or heart failure. Sometimes they can get thromboembolic complications, and very rarely they may not survive a pregnancy, but the most common complications are arrhythmias and heart failure. I'm mostly focusing on women with pre-existing heart disease because they are at much higher risk of having complications. Complications can occur in women who've never had pre-existing heart disease. And I'm going to talk about that briefly down the road. But as I said, for a lot of this, I'm really going to focus on women that we already know have a cardiac condition, which predisposes them to higher rates of complications. So there's been a number of big cohort studies, but this slide shows 3 of the big cohort studies that have been published in the literature. The CARPREG study, and these are all on the x-axis, which is a large cohort study from Canada. The ZAHARA study, and sorry, the CARPREG includes women with congenital and acquired heart disease. The ZAHARA study includes women with congenital heart disease only, and it's from the Netherlands. And the ROPEC study is a multinational study that includes women with congenital or acquired heart disease. The y-axis shows the rates of cardiovascular complications during pregnancy for the whole cohort. And what you can see is it varies anywhere between 8 and 15%. But the bottom line is a significant number of women with pre-existing heart disease will run into troubles during pregnancy. Most of those troubles relate to the dark blue bars, which represent heart failure, or the lighter blue bars, which represent arrhythmias. Only rarely do more serious things happen. But those are kind of in general, if you see large amounts of women with heart disease, what type of complication rates you'll see. Not only do we see complications during pregnancy, but also for those women that have complications in pregnancy, what we see if we follow them over a period of time is that they're more inclined to have complications over the long term. So this is a graph looking at years after the first 5 years after you deliver. And the y-axis shows the rates of heart failure and arrhythmias, predominantly cardiovascular complications, but primarily the development of heart failure and arrhythmia admissions. And the blue line represents women who had no troubles in pregnancy. These are all women who have, for instance, congenital heart disease. So there's more than 400 of them. The blue bars are the women that never had any troubles during pregnancy, and the red bars represent women who had a cardiovascular complication in pregnancy. And what you can see is what happens in pregnancy seems to be a marker of what's to come. Those women that are represented by the red line were more likely to have cardiovascular complications after their pregnancy. Now, whether that's the chicken or the egg, we don't really know. Whether or not these women are just higher risk in general and they get into trouble in pregnancy and after, or whether or not pregnancy somehow impacts their natural history and causes more complications, and it may be a combination of both, but certainly what happens in pregnancy does have, is associated with what will happen after pregnancy. And so thinking back of lifetime cardiovascular risk, that original graphic that I showed you, we also factor in what happens in a woman's pregnancy. And we factor in what happens from a heart perspective. If they developed heart failure arrhythmias, did they take a hit? Is their ventricular function worse for wear? Will that impact their lifetime cardiovascular risk? And also we think about those other complications. So I've talked about the cardiovascular. Now I want to focus on these adverse pregnancy outcomes related to hypertension, preeclampsia, and fetal outcomes. We call these adverse pregnancy outcomes, or APOs. And what we know is that they're related to placental dysfunction. So as a reminder, the placenta is a de novo vascular bed. So presumably it is part of the it is a part of the cardiovascular system. And when the women are either predisposed to develop cardiovascular disease or perhaps develop it de novo, the placenta may not function normally. And placental dysfunction has clearly been associated with those adverse pregnancy outcomes that I just showed you. And these complications actually provide some insight into what will happen after the pregnancy and the mother's long-term cardiovascular health. So if we just look at the risk of cardiovascular disease after pregnancy in women with some of these APOs, and we look at the increased risk, the effect size, if you look at women who had moderate preeclampsia, they have a 2.4-fold increased risk of developing cardiovascular disease after pregnancy. If they have severe preeclampsia, it's almost a 3-fold risk. If the babies never grew, presumably because the placenta didn't work, if they were stillbirths or low birth weight, you see there's increased risk of maternal cardiovascular disease. So again, those complications that occur in pregnancy seem to predict maternal cardiovascular health over the long term. And so if we put it all together, when you're thinking of what a woman's risk is, I think often in a cardiac clinic, we either talk about their ASCVD risk factors and how to modify them, or what's wrong with their heart if they have a cardiomyopathy or valve disease. But please also remember to ask about pregnancy, not just about if they got heart failure arrhythmias, but if they had those adverse pregnancy outcomes, because those are all important when you're actually risk stratifying women for their lifetime cardiovascular risk. And I say, again, I've highlighted those pregnancy complications. So how do we even use this information? Well, we do conceptually think of pregnancy as a stress test for life. So what happens in pregnancy gives us a clue to what's coming. And this is a graphic that was drawn up really for preeclampsia, but it really relates to any type of cardiovascular risk. So on the x-axis, you see a woman's life trajectory, including pregnancies and middle age down the road. On the y-axis, you'll see vascular dysfunction, but it really should say cardiovascular dysfunction. The green line represents the state at which you get a clinical adverse outcome. You actually get disease enough that it manifests itself clinically. And if you look at the blue line, which just represents healthy young women, what you'll see is during pregnancy, they may have a stress on their cardiovascular system. It may even cause some abnormalities in the cardiovascular system, but it never really becomes so noticeable that it crosses the green line, which is the threshold for cardiovascular disease to be detected clinically. So they may have a stress, but it goes undetected. For those women with pre-existing heart disease or predisposed, atherosclerotic risk factors who are represented by the red line here, what they see is their baseline risk is already higher. The stress of pregnancy impacts them more. It actually impacts them enough that that red line crosses the green threshold, and we see complications in pregnancy, whether or not that's preeclampsia or adverse fetal outcomes or heart failure. really, you know, it doesn't matter which one. It's the bottom line is they started with some predisposition that they couldn't tolerate the stress. And then it returns back to normal, although maybe never really back to normal after a pregnancy. And if they have a subsequent pregnancy, the same thing happens again. And perhaps over the lifetime, they have this accelerated trajectory now by having those adverse events in pregnancy. Ideally, though, what we'd like to do is change that course. And if we detect women who've had an adverse outcome in pregnancy, so this is that same graphic with the women with pre-existing heart disease who get pregnant, have an event, that identifies a woman whose lifetime trajectory is higher. And ultimately, the idea is to identify those women early, provide increased surveillance, modify lifestyles, factors, if there's some that we can change that can modify their risk profile, perhaps more aggressive treatment, for instance, if they have cardiomyopathy or valve disease. And the idea is we have a clue that trouble is coming and we should identify these women and use the information accordingly. So I want to do a little pivot now and talk really about pregnancy risks in women with the heart disease in a little bit more detail from a cardiovascular perspective of what you should do for clinic. So I've showed you this graphic already and already mentioned that during pregnancy, you know, maybe roughly 10% of women will develop complications. Here's a few examples. This is a 35-year-old who had a leukemia in the past, had anthracycline cardiomyopathy after her leukemia treatment. She originally had an EF of less than 20%, but ultimately it improved and she became pregnant. And here's what happened. Here's her echo before pregnancy. It was more or less normal. And then she came in a week after her pregnancy, did fine, no complications. But here was her heart on the right-hand side of the screen. And what you see is she now has severe LV systolic dysfunction. So she simply didn't tolerate that prolonged hemodynamic stress. She ultimately was treated and improved, but not all women improve after pregnancy. I've already mentioned that pregnancy is a prothrombotic state, and here she is again. So not only did she have severe LV systolic dysfunction, but she also had a big echogenic mass at her LV apex, which was a thrombus. So she also developed an LV thrombus. This is a woman who had been totally stable prior to pregnancy, 30 years old, non-obstructive hypertrophic cardiomyopathy. You can see the thick LV septum and LV lateral wall here on this echocardiogram. She also had an ICD put in because of a very strong family history of sudden death, but she had never had any issues and she was on metoprolol. Anyway, she presented at 35 weeks with syncope. For the first time, she actually had a cardiac symptom. When her device was interrogated, she had ventricular tachycardia. So she was switched to Sotalol. Then she developed spontaneous rupture of the membranes at 37 weeks, soon after that event, and then had more VT at the time of labor and delivery. She ultimately did fine with adjustments of her antiarrhythmics, but just highlighting that arrhythmias can be precipitated in women, even those that have never had arrhythmias before. I think this case also highlights another important fact that, when moms are unwell, like this woman getting recurrent ventricular tachycardia, it tends to impact the fetus. And what you can see is she delivered spontaneously. And for women that get really sick, you often see associated low birth weight babies. You can see really sick babies. You can see premature delivery for sure. And so I just wanted to highlight that the mother and the baby's health are closely intertwined, and the healthier you can keep a mother, the better it is for both mom and baby over the course of pregnancy. I also didn't mention in my earlier slide talking about the hemodynamic effects of pregnancy, the effects on the aorta. So one of the impacts of having increased stroke volume is you push more blood through the aorta and stretch the aorta. And in addition, the hormones of pregnancy impact the cystic media. So the aorta is more predisposed to dissection in pregnancy. And this is a case of a 30-year-old woman who had Marfan syndrome. She had been on beta blockers before pregnancy. Her aortic aorta dimensions were normal before pregnancy, but she presented with chest pain. And you can see there's a big, long type B dissection in this MRI scan going all the way down the descending thoracic aorta. And so, although I didn't mention it earlier, certainly women with inherited aortopathies and aortopathies from other causes can be at risk for complications during pregnancy. Now, I've mentioned all those cardiac complications, but as I mentioned earlier, we're seeing this increase in acquired heart disease. And what we've noticed is that women who have pre-existing heart disease, like congenital heart disease or cardiomyopathies or some form of heart disease before they get pregnant, if they also have some of those acquired conditions, they're at higher risk. So this looks at all women who have pre-existing heart disease. And on the x-axis, what you'll see is different body weights: underweight, normal, women who have overweight or who have obesity. And you'll see the rates of cardiac complications during pregnancy. So again, the baseline is every woman here has heart disease, but what you can see is those women, for instance, who have obesity, their rates of cardiac complications are even higher than women who have a normal weight. And so presumably there's also, it's not just about having heart disease itself, but you can get a double hit if you also have superimposed acquired cardiovascular risk factors, kind of highlighting the need to really modify everything you can to try and improve pregnancy outcomes for these women. So going back to this slide again, looking at cardiac complications in pregnancy, I haven't really mentioned these red bars, but the red bars represent maternal mortality. It doesn't happen often, but it is really important to be aware of it and be aware of what type of maternal mortality can occur because it obviously has major implications for the mother or the baby, the family. And one of the big problems is, at least in the United States and presumably in Canada, although data is less good, there's been an increase in maternal mortality for more than 3 decades now. When you look at the causes of maternal mortality, unlike back in the day when moms died from bleeding or infection as the main causes, what you see now is if you look at all the 7 top causes, for instance, in the United States, 3 of them relate to cardiovascular disease. So actually the major causes of maternal mortality now in many countries relate to cardiovascular disease. And so cardiovascular physicians and allied health professionals really need to be aware that cardiovascular disease occurs in young women during pregnancy. And this is just data from the confidential inquiries into maternal deaths from the United Kingdom. They've been presenting information about maternal deaths for many, many, many decades. And and a relatively recent one just lists the cause of maternal deaths. But you can see it's ischemic deaths, sudden deaths, myocardial disease, aortic dissection. So one thing I will say about all those causes is many of those women actually don't know that they have cardiovascular disease before they present either in extremis or even after a maternal mortality. Here's some examples. So a woman died after the birth of her 2nd child. She had had a history of unexplained collapse and actually had been referred to a neurologist because of her syncope. But no cause was found. They said it was nothing neurological. She had actually had an ECG that showed a prolonged QT, but nobody investigated it. And in fact, she had long QT syndrome. That was the cause of her death. The diagnosis of long QT was actually made on genetic testing at her postmortem exam. Here's another case. This is a woman that came in short of breath. She was just told it was because she was anemic while she was pregnant. She became progressively more short of breath, more tachycardic over the course of pregnancy and came in preterm labor. She was wheezing when she came in, but nobody took much notice, never thought that it could be the equivalent, a pulmonary edema equivalent. She even got blood gases that nobody acted upon, even though they were abnormal. And after she delivered, she collapsed and died. And she had peripartum cardiomyopathy. So again, this is a de novo condition. These really serious things sometimes can be conditions that just develop during pregnancy. And here's my final example of things that can happen. This is a woman who had some risk factors for coronary disease, came in with chest pain immediately after she delivered. Because she was young, they weren't really clued into the fact it could be cardiac in nature. She had a normal ECG. They never even bothered to do serial ECGs or troponins, and she actually was discharged and died shortly after. And she had spontaneous coronary artery dissection, which many of you may know is increased risk. Women are at increased risk during pregnancy. So those, I wanted to highlight that sometimes really serious stuff, women aren't even aware of it before they get pregnant, or it develops de novo, like spontaneous coronary artery disease. Now, going back to that slide I showed you earlier, looking at the causes of maternal mortality in the United States, I've added part of the graphic on the right-hand side, but if you look at preventability for these really serious complications, what you see is, close to 70% of the cardiovascular disease, the condition is preventable. So I think there's a lot more we can do, and certainly in North America, there's a lot of push to develop new initiatives to try and address this. So the last aspect I want to cover is really, I want to talk about standards of care in this population. And there's a number of documents that address standards of care. One is this scientific statement that came out a couple of years ago, just talking about some general principles. I think it's a reasonable general guide. I think if you really have a woman who has heart condition, who's truly, you need some guidance on what to do, your best bet is to go to this document. It's the ESC guidelines for the management of pregnancy and heart disease. It's on its second version. It's got collaborators from around the world, and it really gives you a lot of more granular advice about how to manage conditions during pregnancy. I'm going to just do a plug. We have a really nice Canadian document that I think gives good information as well. And then sometimes to get specific information, you have to go a little specific into guidelines. So for instance, there's guidelines specifically about how to run cardiac arrest in women with heart disease. The valve disease guidelines include management of pregnant women with heart disease. There's a new arrhythmia guideline statement from the Heart Rhythm Society. So sometimes you have to go to specific guidelines, but certainly there's quite a bit of literature out there nowadays that can help with management. I'm going to go back to this very general AHA statement, just because I want to touch on a couple principles. The first principle that the AHA statement makes is that a general understanding of cardiovascular disease during pregnancy should be core knowledge for all cardiovascular physicians. So really that's all of us and allied health professionals, as I've mentioned it, because cardiovascular complications are now the main cause of complications and maternal mortality during pregnancy. So we need to be aware, and we need to try to not miss things. And, part of educating yourself is talks like this, where you do get some exposure to this field. The other general principle is that preconception counseling is essential for all women who have heart disease or who have a history of preeclampsia. So that means when you're seeing women in your cardiac clinics, are you asking them about pregnancy? If they're interested in pregnancy, do they understand the risk? Is the risk prohibitive? Should they not get pregnant because their life would be in jeopardy? And so it's really important to start knowing that this should be tackled in our cardiovascular clinics. When I started, this just was not something we talked about that much, even though it was part of the training I did many years ago. But I think people are doing a much better job of incorporating pregnancy into their cardiac clinic discussions. So I wanted to briefly talk about a tool for preconception counseling. There's many ways to figure out what the risk of pregnancy is, so you can talk to women. You can just go look up aortic stenosis, see what's in the literature, talk to women, but it's sometimes more complicated than just looking up a lesion, because women aren't just a lesion. They may not just have tetralogy of Fallot. They may also have a history of heart failure. They may have had arrhythmias. They may have, they may be on certain medications. They may have ventricular dysfunction. And so it's not just about their lesion. And so I think it's good to look at their lesion. You can look up the literature. There's a classification system we call the WHO class that just lists lesions, and it tells you if they're a high, medium, or low risk lesion. And I think it's a great starting point. But certainly I've spent a lot of my career thinking about risk stratification. And I think there's more nuances than just simply thinking about a lesion. And so this is a risk stratification algorithm that Dr. Sam Su and I proposed and wrote about in Brunwald. And so I was going to briefly show it to you today. So I think the very first thing you should do when you see a woman with heart disease is decide, do they have a really high risk cardiac lesion where pregnancy is prohibitive? So the high risk cardiac lesions, the good news is there's not many you need to remember, but here they are. I always tell my trainees, these are really the ones you need to remember, because these are the women you need to identify, because maternal morbidity and mortality is sufficiently high. These women really should know that we advise against pregnancy early on so that they can take precautions like use safe and effective contraception. So pulmonary hypertension from any causes on this list, peripartum cardiomyopathy where their EF doesn't fully recover. If they want another pregnancy, it's high risk. If they have a bad EF, less than 30% is what the experts have decided upon. If they have severe symptomatic aortic stenosis or severe even asymptomatic mitral stenosis, if they have Marfan's disease with a dilated aorta, or if they have a Fontan operation with complications or a coronary artery dissection or aortic dissection. So if they have one of those, it's relatively simple. You'd advise against pregnancy. Now, if they don't have one of those, it is more tricky. And as I said, you can look at the WHO class, find the lesion. But I also think you should think of patient-specific considerations. And one way to do that is to use these risk scores. The risk score I've been involved in developing is called the CARPREG-2 risk score. And I'm going to just walk you through it a little bit. But what happens when you use a risk score is you can identify those women that are low, intermediate, or high risk, and then provide them again that information, give them the information so they can make an informed decision about if they want a pregnancy. If they're actually already pregnant, it gives you some tools to decide on what kind of surveillance you'll need, and also to educate them about what they're going to expect going forward with the pregnancy. So the CARPREG risk score is here. On the x-axis, what you'll see is there's a point score that women get allocated. On the y-axis, you can use those points to predict what the complication rates are in pregnancy of maternal cardiovascular complications. And the risk score includes these 10 variables in it that I've got listed in the box. It's a weighted risk score, so different variables have different weights. We are coming up with a risk calculator that will be available for all. Hopefully that'll be coming soon. But in the meantime, you know, it is a weighted risk score. I think it is a little tricky to use because it's a weighted risk score. But I think what you really just need to know is what are the variables in the risk score that are clinically that you need to start thinking about, because they are variables that identify a patient at high risk. So the first thing you want to do is take a history. If they've had a history of arrhythmias or heart failure, they get points. In fact, they get 3 points for that. Take a history again. If they have poor functional class, they're at higher risk. Do a physical exam. If they have cyanosis, they're at higher risk. Do an echo. If they have ventricular dysfunction or pulmonary hypertension, they're at higher risk. Then there's just some lesions that are higher risk that I've already kind of alluded to. If they have mechanical valves, left-sided obstructive disease, coronary disease, aortopathies, they get points because they're at higher risk. And then one I've always found interesting is that if they don't get early pregnancy care, they're also at higher risk. So those women that show up late in the game are more likely to run into troubles. And presumably, or hopefully it's just because they're not, you know, it means that your care makes a difference. Without good antenatal care, they're more likely to run into trouble. But basically, you tally up the points, and the more points you have, as you can see on the x-axis, the more likely you are to have maternal cardiac complications in pregnancy. And if you have more than 4, you can see the rates of complications, is really high here. Now, it's one thing to tell women, you know, here's your risk of complications in pregnancy. Here's what we know. Here's what we plan to do. But ultimately, you know, every woman has to decide what their risk threshold is for a pregnancy. And certainly some women that are actually at relatively low risk for developing cardiac complications may just decide that risk is not acceptable. And even though the risk is low, they just may not agree that they want any risk. And there's other risk, women who have very high risk lesions, you know, who even have a significant mortality risk that will decide what they want to do no matter what is to have a pregnancy. And so although we advise them, I just put up this slide to remind everybody that, you know, ultimately it's a patient's decision if they do or don't want to have a pregnancy. And our job is to inform them, educate them, and then support them on whatever decision they make. So back to standards of care. After you tell them what the risk is, for those that become pregnant, it is really important if a woman has an intermediate or a high risk that they are referred to a center that has some expertise in pregnancy and heart disease, like the one I understand has been nicely and newly established in Colombia. I'm so happy to hear that. But it is really important for the really high risk patients to be seen in a center where you can coordinate care. And this is one of the examples of why coordination of care is needed. These are some of the things we need to do for these women. They need the preconception counseling, as I've mentioned. They may need genetic testing, not necessarily only for the mother, but really you may do cord blood sampling if you have transmission of heart disease to offspring. You have to decide on clinical surveillance. That includes clinical visits and serial echoes, especially for women with more complex forms of heart disease. You might even need to do MRIs if they have aortopathies. You need fetal echocardiograms if women are at risk for transmission of heart disease to their offspring. You may need placental studies. You need other antenatal tests that the obstetricians do. You need to plan the delivery, decide the mode of delivery, how you're going to or what kind of monitoring you're going to need, where you're going to monitor the woman after she delivers, and then ultimately when to get them home safely, when to bring them back. So you can see it's a complex process, and you do need expertise. But not only do you need expertise, you need lots of players here. The cardiologist can't do everything here. The geneticist can't do it. The hematologist can't manage anticoagulation on their own. It's really a team effort. And so, you know, that has brought about this concept of the cardio-obstetric team, kind of like the heart valve team, or, you know, there's so many teams in cardiovascular medicine nowadays, but certainly there's a really critical cardio-obstetric team that needs to be assembled for these high-risk cases, which is why you want to get these women in centers where these teams can be assembled quickly and there's expertise in working in a multidisciplinary fashion. So not only the cardiologist, but that team will also include the high-risk obstetricians, the obstetric anesthetists, any other specialists you might need, like imagers or surgeons or interventionalists or other internists. I've mentioned OB hematology. You also need the nurses to be comfortable with cardiac patients. Not all obstetric nurses are going to be comfortable with cardiac patients. And then, you know, you may need other specialists depending on any individual case. This is an example of what we do. You know, we have combined rounds when we have really complex cases. We bring everybody together. Back in the day here, it was in person. Nowadays, it's much more likely to be on Zoom, but we have Zoom meetings and everybody offers their advice about management of really complex cases. Then we come up with a delivery plan and a pregnancy plan that gets disseminated widely to everybody involved in the patient's care, including in the electronic health records. So everybody can access it. And we really work with a multidisciplinary perspective. And this is my cardio-obstetric team here in Toronto. And a lot of what I've presented is because I've been fortunate enough to work with a really great group of obstetricians, maternal fetal medicine specialists, obstetric anesthetists, and of course, cardiologists. So my last few slides here really to show you like what's the benefit of having a cardio-obstetrics team. So this is data from Toronto. It's more than 1,000 patients that were followed in 2 time periods. So the blue bar represents women that were followed between 94 to 2000. In Toronto. And at that point, we didn't have really a unified cardio-obstetrics clinic. We had things happening at 2 different hospitals, a cardiac hospital, and then across the street at an obstetric hospital. And there was not a unified clinic, and women would come. They would be seen by the 2 team members. And there obviously was expertise in the 2 different teams, the obstetrics team and the cardiac team. but it wasn't a formalized clinic. In the year 2000, the clinic was formalized in Toronto. So, 20 years ago, but or 20 some years ago. But what you can see is the red bars represent women in the era where we formalized a cardiac clinic. So that's where they came in one-stop shopping. They'd see the cardiologist, see the MFM, see the OB anesthetist. If it was later in the pregnancy, they get their ECG, their echo, their fetal studies done, everything done at one spot, everybody done together, everybody sitting together, talking about complex cases, having monthly rounds for complex cases, and a real formal program was established. And then what we did is we looked at those time periods and we looked at the cardiovascular complications. So on the x-axis is the different types of cardiac complications. On the y-axis is the rates of complications during pregnancy. And if you just look at any cardiac complications in that early era of blue bars versus the more contemporary organized era represented by red bars, what you'll see is there's a slight decrease. Wasn't really significant though. In fact, if you look at arrhythmias, the next bars over, there's really no difference at all between the old era and the new era. Where we did see an impact was here. If you look at the cases of pulmonary edema, we dropped them by half by having a really organized cardio-obstetric clinic. And probably to some extent, we've increased or dropped maternal mortality slightly as well in that time period. So it's not perfect. This isn't a perfect study, but I think at least it gives us some hope that all this work we're doing to establish these multidisciplinary clinics really might have an impact on women's morbidity and mortality during pregnancy. So I want to leave you with these 4 thoughts: that we have this very intriguing growing field of cardio-obstetrics. I'm so happy to hear you have an interest in this field locally. The hemodynamic stress of pregnancy contributes not only to cardiac complications during pregnancy, but I hope I've highlighted impacts your lifetime cardiovascular risk, and we all need to be aware of that. All these patients that we see in cardiac clinics that are young need to have some discussion about pregnancy. So preconception counseling is important, and I hope I've given you at least one tool that you might want to consider using. And finally, when you're out there in the world and you got a complex case, remember there are standards of care. I've showed you some of them. That's where you can go retrieve information if you need it. But also remember, these standards of care also are there to help guide us about now what a minimum standard of care is for a woman who's pregnant, who has heart disease, and how we should manage them. So again, they should also be followed because they are some guidance about optimal care in this population. And so I wanted to thank everybody. Again, remember to take a look at JACC Advances. I'm really proud of all the people that have submitted great cardio-obstetric work, and there's lots of good stuff coming in this field in the journal. So thank you for everybody, and thank you for letting me be here this morning. I'm happy to take any questions.
Dr. Silversides, thanks for your excellent presentation. We have a lot of interesting questions, but first I would like to give you a few comments to give you some local context about demographics. For example, we have in average a younger maternal age, and pregnant teenagers is still there are still an important issue here. We have for sure lower numbers of obesity and overweight women, but we are fully aware that it is an increasing pandemic also here, even in middle income countries. We have a lot of boundaries that, for example, social, cultural, geographic boundaries that make even a bigger problem for the heart disease in pregnancy. And our data is very interesting. We presented in 2021 in cardio-obstetrics around the world that, for example, talking about adverse outcomes in pregnancy, we have almost 15% of cardiovascular and obstetric outcomes and almost 30% of neonatal outcomes. Higher numbers than what you saw on CARPREG and other risk.
This is
scores.
such amazing data. I just want to tell you, I congratulate you immensely on collecting it, because I'm very well aware of how hard it is to collect. But keep going. It's intriguing. Keep going. Tell me more. I've seen you present, but I keep reminding me. So
Today we have somewhere around 900 patients in our database, but
amazing.
it's an increasing collaboration. We're doing more research, and we have a lot of questions. I'm gonna start with the chat. I have a question, and it's about the use of bromocriptine in peripartum cardiomyopathy.
Yeah.
We don't use it here because of as you know, there's a lack of data and efficacy based mainly in the studies of Dr. Sliwa and collaborators. So we don't use it here, taking into account the cost for the system and as I said, the lack of efficacy. I don't know if you're using it there in Toronto, or
Yeah,
what are
no,
you
we don't use it either. I mean, part of it is because there isn't great data about the efficacy for sure. And, there's also some downsides. Remember, it is potentially associated with thromboembolic complications. Women with peripartum cardiomyopathy, independent of bromocriptine, are at risk for LV thrombus, kind of like that one I showed you. And so, we don't have good data. There's maybe a downside. So I can tell you that we haven't elected to routinely use it. It hasn't hit a class 1 level of guidelines in North America. It's very different in Europe, where I think there's bigger proponents of it. In North America, not so much. And it's not even just so locally we don't use it. Until good data comes out, we've elected not to use it. But just so you know, it's not even us. The main peripartum, probably the most detailed peripartum study is called the IPAC study. And even in IPAC, which represents women treated in the United States, almost none of them received bromocriptine. So I think in North America, and I guess, in Central and South America, maybe we're all similar in that it hasn't been used to the same extent as I think as it has in Europe. What's happening in North America is that they're trying to run a big trial to actually get to the bottom of it. Maybe there will be subgroups where it's effective, but it's just not really clear right now. And so the big trial run by Dennis McNamara, who's one of the big peripartum guys out there in the world, is a randomized trial to figure out if it works, and if it does work, in which populations, or alternatively, if it doesn't work. You do have to remember, though, if you are going to use it, you also have to anticoagulate women because of this thromboembolic complication risk. So if you're going to use it, just remember it's also more complicated. You got a postpartum women usually, because that's when they usually present, and they've just delivered, and you're going to need to anticoagulate them. So, I don't know what the right answer is. There's people around the world do it differently. I do think in North America, in Canada, and United States, we tend not to use it. So I guess we're fairly similar to you.
Thanks. We have a very interesting questions here from one of our fellows, and it's about potential overestimation of the risk with some risk scores. And it says that, for example, in pulmonary hypertension of coarctation of the aorta, there's some recent evidence that show us that maybe the risks are not so high. So what do you think about it?
Yeah, I think no risk score is perfect. Don't get me wrong. So by the way, if you had repaired coarct and you were fine, you'd have really no points on the CarPreg score, and you would be fine. But it is true. So, this field we're learning. So back in the day, everybody said coarct risk is high, high risk of hypertension. And you're right. A recent study showed maybe the risk isn't really nearly as high as we thought it was in the past. And, we also get better at delivering care, so risk may be modified. But the bottom line is risk scores and CarPreg risk score. I've been totally involved in the CarPreg risk score. It is absolutely not perfect. Never assume it's perfect. It's a tool you can use, but it's only a tool. It may overestimate, it may underestimate. In the end, being a clinician is what's most important. Take in all the information, you can use. Look at the WHO class. You can look at a CarPreg score. There's a whole bunch of variables that are not in any score that may be relevant. Maybe you have exercise stress test data. Maybe you have MRI scans. Maybe you know something about the family history that's really, really relevant. And so in the end, I would say they're only starting points. They're all limited by the fact your risk score is really based on the cohort that you develop the risk in. So if you develop, you saw the Zahara score that I showed where the risk is much lower, and that is because it's only in women with congenital heart disease versus those with cardiomyopathies and acquired valve disease and other things. And so they have a very different risk profile and different risk predictors because the cohort that the risk score was established in was very specific. And so, yeah, it's a good point. Whoever brought it up, thank you, because all I would say is risk scores or tools, they're not perfect. Use your clinical judgment. If your gut instinct tells you it's not right, it's probably not right, and you're probably right.
Thanks. I think that also answers another questions in the chat. We have two more questions about logistics, about the cardio-obstetric teams and multidisciplinary teams. So one of our professors, Dr. Jaramillo Gomez, asks you if you have some help resources, including telemedicine for other clinicians that are beyond your group. For example, in Canada, a largest country, how do you for example, do you have some networking or telemedicine resources for help, for example, an obstetric team in a far area from Toronto?
Yeah, so that's a great question. Logistics are an issue for every single place, everywhere, and maybe even worse for Canada, where we're geographically so spread out. We have people drive for 10 hours to come. Well, they fly, they don't drive. Sometimes they drive. Yeah, it's logistically, it's tough. We obviously will use virtual visits if we need to. We've also tried to work closely with local teams. So for low risk lesions where someone can deliver locally, we might bring them down and see them, give and send a consult back with detailing all the recommendations we would have, but they deliver locally. We've tried to train people so they're not all just in, Toronto's a city of 5 million, but everybody can't be in one little small site. So we've tried to train people and move them around to different places. But yeah, logistics are tricky, and even simple logistics, like a lot of places, your cardiac hospital is in a different hospital than your obstetric hospital. And so you've got to figure out how to get cardiac coverage in what's otherwise mostly an obstetric hospital. For sure, that happens in lots of places. And, I think a lot of places, the cardiologists go to the obstetric hospital and provide backup, but the logistics are very tough. And in some ways, that's why you need to create those teams, because you need to sort out these logistical issues well in advance and figure out how you're going to deal with it instead of trying to deal with it when someone acutely ill shows up. You need to figure out a way you can mobilize teams and get them to move around. But in Toronto, when we need people to move around, it's basically having people jointly appointed and then trying to create a hub and spoke model where other hospitals at least have somebody with at least some knowledge. Remember, in Toronto, we've been doing this cardio-obstetric thing well before I ever came and did cardiology. They've been doing it since really the 80s, shockingly. And so, I had the good fortune of walking into a group that had been already doing it for more than 20 years by the time I started. And so it's still a majorly difficult thing, but I would say over time you can sort out some of the logistics. Logistics are hard. That's all I will say. Those are some of the things we do. I guess you have to figure out the logistics for what's going to work for you locally and how far away you are. One last thing, women that are really high risk fly in. We have a little suite in the hospital that's more like an apartment, not a hospital room, and they stay in that apartment until they deliver, or we put them up in a local hotel. So the really high risk women from who knows where in Canada will come into town, at some point in that third trimester when we think it's optimal, and they basically live in a hotel waiting to deliver. Or we bring them in if they're going to have a C-section, depending on the case.
Perfect. Would you tell us more about that combined rounds you just show us? How often do you meet? Who are the members? How do you discuss complex cases?
Yeah, so it used to happen in person all the time. Now I said it's mostly virtual. We actually do medical disorders of pregnancy rounds every week. I would say we discuss different cases, and they're not always cardiac. So weekly we have complex cases. I would say a cardiac rears its head about once a month, where we have a cardiac patient that warrants that format, you know, where we really need input. And sometimes if we just have a really complex case and we don't have the format to do it there, we actually just get everybody together and hold a meeting. So we still do kind of offline meetings. The meetings will always include the maternal fetal medicine specialist, always include the cardiologist and the OB anesthetist. You know, the really complex ones, obviously, if it's a severe cardiomyopathy, you bring in heart failure and the ECMO team maybe. If it's a valve, you might bring in the interventional guys in case you have to do something. If it's surgical with an aorta, you may bring in the cardiac surgeons. So beyond the core, and the nurses, the social workers, all that team is there, who also are going to be frontline people dealing with these patients. So everybody comes to the rounds. It's tailored a bit for the case. You know, we invite appropriate people depending on the case, and at least once a month or more if need be, depending on how many complex cases. You know, we would never discuss simple or intermediate cases usually. Usually the cases are only where we really think trouble could happen, and then we need to make sure that all the team knows how to mobilize quickly. Yeah, did I answer all of that?
Yes, perfectly. We have two more questions, little questions here, about the use of natriuretic peptides in pregnancy. How do you use them? And I think that's especially tricky, defining cutoff points.
Yeah, it is. So I'll tell you, when they're normal, they're really helpful. If you have a woman short of breath and you get a normal BNP, it's great, because then you can be rest assured it's not
I'm sorry, do you use BNP or NT-proBNP?
We've used both over the years. So by the way, I've done old studies where we used to use BNP. Nowadays we use NT-proBNP. So we've used different assays, and different hospitals obviously use different assays. But I guess maybe more groups now use NT-proBNP. But if it's normal, it's helpful. If it's not normal and just a bit high, it's hard to know what to make of. You usually have to use clinical judgment, because many women, it's a function of stretch. You increase your stretch of your ventricle and your atrium. And so BNP leaks out during pregnancy. But if it's not really high, then you use clinical judgment. I hate to say that's where you're at. If it's really high, it's probably heart failure. So, you know, normal values are high, super high levels are high. It's the murky stuff in between where it could go either way, where I usually say you have to use clinical judgment. But I would say go to Jack Advances. It's all free, it's all open access, and there's a beautiful expert panel on biomarkers in pregnancy that was written by a group from all around the US. So if you want more info, there's a really nice free summary of that information at Jack Advances. Not trying to just do a plug for the journal, but it's a nice way to access free papers.
Great. And maybe one final questions about main restrictions related to physical activity for pregnant women.
That's a good question. So we don't really know. There's no studies that I think have looked at exactly how you do or don't have to restrict. If they're feeling well, I don't restrict them. If they have really complex heart disease, I would restrict them. But you know what? I have to say there is no protocols out there. Most people, it hasn't really been written about. And I would say I try to err on the side of not being restrictive unless someone is sick and I'm worried about them. You know, if someone is having recurrent arrhythmias that are bad, if they have a cardiomyopathy that's really bad, I would probably tell them, you know, not to do any heavy activity. But incidentally, I mean, Rarely have I ever brought anybody into the hospital and put them on bed rest, with rare exceptions. Yes, there's been 1 or 2 cases of angina with AS or, some badness, but most of the women kind of naturally restrict themselves. I tell them to use their symptoms as their guide. If they feel okay doing it, they're probably okay, but I generally don't restrict them. I know it's not a good answer, but I don't have a good policy, and nor do I know of any place that's written up a good policy by experts.
Do you use
So,
a treadmill test in some context, or it's
yeah,
not?
I love treadmill tests. I even love stress echoes because I'm an echocardiographer. So I think they're helpful to do. I think they give you a sense of how women will do in pregnancy, or at least a rough sense. What I would tell you though is we did a study back in the day. It was led by George Louis when he was in New York. Now he's the head of the program at Stanford, but he got a bunch of us to collect cases and look and try and decide if exercise testing could predict what happened in pregnancy. Interestingly, everybody thought MVO2 was going to predict it. MVO2 wasn't a great predictor of complications in pregnancy in women with pre-existing heart disease. What was the best predictor was conotropic incompetence. If you couldn't mount a normal heart rate response to exercise, you were more likely to run into trouble. So I think it was a bit surprising because everybody thinks MVO2 is going to do the trick. I still think MVO2 is really useful, but just so you know, that old Circ study we did said actually you get more bang for your buck if you look at how the heart rate responds to exercise. But nonetheless, I do use it. And the other advantage is those were just based on regular exercise tests. Getting a stress echo also tells you about ventricular reserve, your RVSP in response to exercise, a lot of other parameters. So I love them. It's just often you don't know when somebody's going to get pregnant. And so timing the stress echo to relative when they're going to get pregnant, we don't always have the timing perfect, but I tend to use them when I can. I think they're helpful.
Thanks a lot, Dr. Silversides. I think we have had an amazing session today. We learned a lot. We feel really grateful to you, and I think we can finish now. Thanks a lot. And you're very welcome here.
And congratulations on your amazing, amazing program. It just brings joy to my heart to see a program established like that. Really, that is the way we will improve outcomes. So congratulations to you and your team.
Thanks to you, and have a nice day.
You too. Everybody have a good day. Okay, Emilio. Thanks for inviting me.
Hi, Professor. Thanks to you.
I hope I cross your paths someday soon.
I hope it too.
Maybe. What meetings would you be at? Do you make it to any meetings?
I'm sorry?
Will you make it to any pregnancy meetings someday? Do you think I'll see you at a pregnancy meeting?
If you want it, we can make it. We can arrange it.
Well, all I'm saying is I hope someday we meet in person at a cardiology meeting.
Okay, I hope it too. I hope we'll stay in touch.
Yeah.
We'll email you.
Okay. Yeah. Good luck with everything. And if we're ever at a meeting together, please come and say hi to me so we can meet in person. Like I'm saying, do you ever go to like the American meetings like AHA or ACC or anything like that?
I haven't, but it's in the plan.
Okay. If you ever are there, you come and find me.
Okay. Thanks. Have a nice day.
Anyways, great work. Amazing stuff you're doing. Truly amazing.
Thanks.
Okay.